The quality of CPR, rate, depth, release, minimization of interruptions. Those things improve survival in cardiac arrest both in and out of the hospital. Manual CPR is hard to do. It's hard to perform well, and it's fatiguing. In fact, the older I get, the more fatiguing I find it to be. Machines are generally better at doing repetitive tasks, particularly ones that are hard to do manually. Now, several mechanical compression devices, or MCDs to stay brand neutral, several of those are out there, and boy, are they heavily marketed. If you've been to an EMS or fire trade show in the past 10 to 20 years, you've seen lots of large, fancy, very well-carpeted booths promoting the greatness of MCDs. If you were to conduct a survey of a random selection of conference attendees, or even do a random sampling of fire or EMS stations, and you ask about the impact of these things on mortality, I'm guessing you'd find that most clinicians would say these things save lives. You might even encounter some strongly held convictions, specifically expressed with great passion, just like they were on Twitter. But, as we discussed in the last episode, the devil's in the details. What did the details show? What does the literature say? Now, I'm feeling a little bit guilty on this topic because other than a few episodes talking about head-up CPR, and the Lord knows I don't want to touch that again, I really haven't talked much about MCDs. What's time to do something about that? Now, I just finished a cross-country road trip with my daughter, Sydney, as she looked at PhD programs. Turns out she wants to do EMS research. She wants to be Rimley when she grows up. I have no idea where she gets these ideas. Well, it was a 2,200-mile road trip, and there was a fair amount of driving, but there was also a fair amount of time to browse PubMed. We found a new paper on MCDs. Sid liked it, and she thought it'd be a good place to kick off a couple of episodes worth of MCD discussion. Stick around, we'll be back to discuss a new paper on mechanical compression devices and mortality from in-hospital cardiac arrest.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of modern clinical practice. Now, before we get started, I wanted to wish everyone a Happy New Year. Today's New Year's Eve. Specifically, it is 6 o'clock in the afternoon in Texas on New Year's Eve. I'm feeling festive. I'm sitting here. I'm recording a podcast. I'm drinking my flavored Topo Chico like the nerd I am. And I'm trying to knock off those last few to-do items off my 2024 list. But because I'm a paramedic and an EMS doc, I got distracted by the shiny thing that was this paper. Well, I think I can record, edit, and publish this episode in the remaining 6 hours of the year. The coffee's on. It is a gorgeous afternoon here in Fort Worth. Football is tomorrow. Go Ducks, go Longhorns. As an Aggie, that pains me to say, but I am a Texan, so should be great football tomorrow. So let's talk MCDs. If I were writing an introduction section for a paper on MCDs, I think I'd summarize what we know like this. A bluff. Bottom line up front. So here goes. Let me give this a try. Multiple well-done randomized control trials have studied the use of various MCDs on survival from out-of-hospital cardiac arrest, yet none have shown improved mortality. These include the LINC trials, the paramedic trial, the CIRC trial. There have been plenty of observational studies with mixed results. Some show improvement in ROSC and some show improved survival in these observational studies. Most, however, show either no difference or some even show worse outcomes. Application of the device can lead to prolonged compression interruptions and long compression intervals, but systematic training with programmatic use can decrease these interruptions. There have been several systematic reviews and meta-analyses of all available evidence and have found no evidence of benefit. The 2020 ILCOR recommendations do not recommend MCDs. That's their way of saying, nope, doesn't seem to be enough evidence to suggest these things. Now, I would say the summation of the evidence says MCDs do not improve mortality. I want to be clear, though, that that doesn't mean I don't think there's some specific situations in which MCDs might make sense. Things like intra-arrest transport, something that probably ought to be rare. Intra-arrest catheterization or cannulation for ECMO in hospital, prolonged resuscitations with minimal manpower, and maybe wilderness situations. In my system, we use MCDs after the first 15 minutes of resuscitation. We use it for those rare situations where transport without ROSC is indicated. We use them prophylactically in post-ROSC patients during transport and in those isolated areas in our system, isolated anyway, where we have limited manpower. Or at least that's how we're supposed to use them. Now, that's the best summation of where the evidence currently is on this topic. To be clear, all of that evidence is about out-of-hospital cardiac arrest. There's very little in-hospital evidence. Which brings us to our paper. The title is The Association Between Mechanical CPR and Outcomes from In-Hospital Cardiac Arrest, an Observational Cohort Study. Lead author is Connor Crowley, and it was published in Resuscitation earlier in 2024. The authors conducted an observational study using the AHA's Get with the Guidelines Resuscitation Registry. Now, if you're not familiar with this is a registry of in-hospital arrest with the data entered into validated online tools by trained abstractors using standardized definitions. Data is entered in more or less at the time of discharge. And again, it is abstracted from charts. Now, this is in contrast to the CARES registry of pre-hospital arrest. That includes automatically exported data from EPCR records or manually abstracted data. Your choice how to populate CARES. Now, abstractors review all available hospital medical records to populate the Get with the Guidelines registry. They include all in-hospital arrest, regardless of etiology, of adults among the 153 participating hospitals. This study used that data specifically from 2011 to 2019, excluding data after 2020 to avoid confounding by COVID, because COVID is why we can't have nice data. Now, they had some important exclusions, including any arrest that occurred in the ED. Now, much like out-of-hospital cardiac arrest, these are fundamentally different patients who arrest after admission to the hospital. ED and ER patients, we see them because of the arrest or because of the chest pain that led to the arrest, as opposed to patients who were admitted for something else and got so sick that they arrested. So, different population. This study also excluded arrest with less than 5-minute duration of resuscitation or more than 120 minutes. Their assumption is that less than 5 minutes duration, you're probably going to get ROSC back quickly no matter what, and you probably didn't have time to get the device on, and greater than 120 minutes is likely to be a data entry error. Now, finally, they excluded patients with missing data. Now, excluding patients with missing data is a pragmatic choice with these observational studies because, well, it's really hard to study something that isn't there. And as we all know, all data is dirty data. But this exclusion should raise red flags about whether the patients with missing data are somehow different than patients with data present. It's just a limitation of studies, and good studies try to address it by doing sensitivity analysis, among other things using imputed data. Now, it turns out that's exactly what these guys did. They took this data set and they separated patients in it into one of two buckets. One is those who received mechanical compression with any device, and the other is those who did not, who got only mechanical compressions. Now, they defined mechanical compressions in this study by using a voluntary field in the registry. Voluntary meaning it doesn't have to be answered, so you could have theoretically one of three values for this field: yes, no, and no answer. There's no data there. So they report that if the value for this field was yes, they categorized the arrest as MCD use, and if it wasn't there, or if it explicitly said no, that was manual. Now, this is a limitation that may have resulted in some patients being miscategorized. The primary outcome here was survival to hospital discharge, and the secondary outcome was sustained ROSC for 20 minutes. Now, obviously, we would love to know the neurologic outcome, but it wasn't reported. Now, presumably it wasn't reported because CPC or MRS values aren't captured in the registry. I don't actually know that. This is a new registry for me. I've never looked at it. I've never done research with it. And honestly, this is the first paper I've read from it. I searched around the interwebs trying to find which elements are included, but I ran into the dreaded paywall. Can't get there. I don't have an AHA login. If anybody who does have one happens to know if neurologic outcome is collected, please drop me an email. I'm really kind of curious about that. Now, survival to hospital discharge, a lot of people will say that's a good surrogate measure for neurologic outcome because typically speaking, if you're discharged home, you're pretty functional. But that assumes that you're discharged home and not to say an LTAC where you live out the rest of your days, 30 of them maybe, on dialysis and on a vent. That's not good neurologic outcomes, so we really do like to see the CPC or MRS codes. Again, you got to do analysis with the data you have. Now, they did several different analyses here, including a multivariable logistic regression, adjusting for multiple confounders and using hospital as a random intercept to adjust for clustering. Seems very appropriate. They also threw in a propensity matched analysis for good measure. Now, in the paper, they didn't describe the covariates they adjusted for, at least in the main manuscript. And I thought that was kind of odd since it's pretty standard to do that. But after downloading the supplemental tables, I kind of understand. They adjusted for, roughly speaking, everything. Specifically, in the regression analysis, they used 29 variables that had both face validity and independent and association. Or specifically, they used 29 variables that had both face validity and independent association with survival. They also included a variable for the frequency of MCD use by the hospital, like what proportion of patients got the MCD in this hospital, and they did that as a surrogate for familiarity with use of the device. And I think that is smart because the more you use it, likely the better you are with it. Now, I just wrapped up the analysis for another paper I'm working on, and my computer right over there, my big strong MacBook Pro, it's having some sympathy pains for whatever machine this analyst used. They did a regression on 100,000 rows of data with 30 variables. That had to piss their processor off. I kind of hope they fed it a strict diet of only email and cat videos for the next week or so to make amends. It's at least what my MacBook Pro is saying. Now, in terms of additional analyses, they did 7 different sensitivity analyses, including using one for multiple imputations to assess the impact of omitting missing data. They excluded hospitals that had no MCD cases, and they also did one in which they excluded duration of resuscitation for more than 20 minutes. All in all, I think this was a pretty solid analysis plan. I think they did a pretty good job with this. Well, let's get to the results. Overall, there are more than 350,000 patients in this registry, but they excluded 250,000 of those for the reasons we already discussed. 47% was for missing data, and that is a massive, massive exclusion. Again, they try to address it, I think the best way they can, but we have to be aware of the impact of missing data may have on the results. Another 17% were omitted because the resuscitation occurred in the emergency department, and 32% were because the duration was either less than 5 minutes or more than 120 minutes. That left the final analysis group of 111,143. Now, of this group, 98% had manual CPR only, and 2% had MCD used. Now, obviously, that is an uneven group, but y'all analyze the data. I have a visitor. This is Groot. Say hi. Hello. Happy New Year. Okay, Groot. I'm recording. Go on. Where were we? 98% had manual, 2% had MCDs. Now, obviously, that's an uneven group, but you got to analyze the data you have, not the data you want to have. It's just kind of one of those facts of life. All data is dirty data. Most hospitals here used MCDs rarely. If you dig a bit more into the supplemental figures, you'll see that about half of the 153 hospitals represented in the registry never used MCDs at all. If you look at the histogram of the proportion of patients receiving MCDs by hospital, it was heavily left shifted. In fact, less than 6% of hospitals used an MCD on at least 35% of patients. Big fancy way of saying these things were pretty rarely used. And it absolutely could have influenced the results, but they wisely did a sensitivity analysis that excluded hospitals that never used MCDs. All right, what does the population look like? Well, most had a witnessed arrest. It's in hospital after all, and that was more than 85% of patients. And more than 60% had an initial PEA rhythm. Again, different population than EMS. And there were some other baseline differences between the groups, most notably with race. 87% of MCD patients were white versus 67% of manual CPR patients were white. Now, I don't know what to make of this, and it seems like the authors don't either. They threw in a couple of guesses, but the bottom line here is it's a clear disparity, and they were right to call it out. Maybe this will lead to a future study that looks more into this. Not a bad idea for a future researcher interested in disparities. Hint, Sydney, hint. Now, MCD patients had a median of 4 minutes longer resuscitation, and more patients with MCDs were on vasopressors before the arrest. I mean, we're talking 66 versus 23% here. Now, these differences were adjusted for in the models as covariates, but again, on their face, they might bias results against MCDs. So what'd they find? Well, the unadjusted survival to discharge was lower in the MCD group, 11.8% versus 16.9%. As was sustained ROSC, it was lower in the MCD group, 46.4% versus 55.9%. Survival was lower in the MCD group. But that was just the unadjusted results. What did the adjusted model show? What were the adjusted odds ratios and confidence intervals? Well, they also showed less survival and less ROSC. Specifically, the adjusted odds ratio for survival was 0.57. That was significant. Confidence interval went from 0.46 to 0.7, not crossing 1. And for ROSC, it was 0.68. Now, also significant. So this translates to 43% lower odds of survival to discharge with MCDs and 32% lower odds of sustained ROSC with MCDs compared to manual CPR. Now, these results of lower survival persisted through all of their sensitivity analyses, specifically all 7 of them. This includes those patients with shockable rhythms and non-shockable rhythms, those with resuscitation lasting longer than 20 minutes, those with resuscitation only between 5 and 20 minutes, those with hospitals that had MCDs even if they didn't use them, and those that excluded hospitals that never used MCDs, and an analysis that looked at only those hospitals that were in the 75th percentile or higher of MCD use. And they found the same results when they used multiple imputation to correct for all those missing values. Now, y'all know I'm a sucker for a nice forest plot that visualizes odds ratios in 95% confidence intervals. Take a look at figure 2 in the paper, and that shows the unadjusted model, the regression model, and the propensity matched models, and they all show worse outcomes with MCDs. So what's my bottom line on this paper? Well, I think they did a very nice job with their analysis. Well done. Strong work. I really enjoyed this paper. It's interesting because they did a smaller study that was just based on their hospital using retrospective data, and they actually found better survival. So they went into this study with the assumption that MCDs would be associated with higher survival despite all of the randomized control evidence. So that was their bias going in. They used a very large registry of abstracted data, and they used appropriate models to attempt to adjust for baseline differences between groups. Now, there are clearly limitations to this paper, as there are with all papers, but I think they did a good job of trying to address them. The biggest concerns I have here are about how they identified whether a patient got an MCD or not. I'm worried about the lack of information on when in the resuscitation the MCD was applied, what type of MCD it was, and the lack of data on neurologic follow-up. Those are my nits. I got to pick nits. Now, overall, I think these results are right, and I think MCDs worsen outcomes in real-world situations. And by real-world here, I mean outside of controlled trials where not only is the manual CPR optimized, that's something proponents of MCDs always point out about all of the trials showing no benefit. Well, that was compared to maximal manual CPR, really, really good stuff. But what they don't point out is it also was really good MCD use, optimal MCD use. So why is this? What do I think the mechanisms for lower survival with MCDs are? Well, obviously, these are just guesses. These are hypotheses, but this is what I think. Number one, MCDs take practice to apply. In real life, there are prolonged pauses during application. Somebody just did a good paper on this, and because I can't remember who did it, I'm going to cover this in a future episode. So we know MCDs take practice to apply. Number two, MCDs walk. In other words, they migrate from where you set them up to push. We've done some work on this here in Fort Worth, and we've documented frequent movement of the piston out of appropriate position. Now, even though the liver is full of blood, compressing it does not do a good job of circulating blood if that compressor, that piston, moves down over the liver. Turns out it also doesn't help if you're squeezing the aortic arch instead of the heart. Doesn't help. Marathon CPR is number three. What do we mean by this? This is something that the folks here in Fort Worth talk about when they see the device turned on in continuous compression mode and all attention goes away. It's on autopilot and we forget to check pulses. Turns out great compressions don't do much for VFib if you're not shocking it. And you don't shock it if you don't know it's there. Now, the number four reason I think is because of distraction. MCDs are great attention magnets. When the MCD shows up, all attention moves to applying it and we forget to focus on good choreography. Now, to be clear, all of these things can be mitigated. It is possible to mitigate them. In fact, Dr. Mike Levy in Anchorage demonstrated how to appropriately apply the Lucas with minimal interruptions. But these lessons are frequently taught, and we always say we do these things, yet we still see lower survival in real-world applications. As a matter of fact, I think our next paper is going to be one really nice study that Luis Gonzalez and the folks from OMD in Austin did that demonstrated exactly this thing in an upcoming episode. So that's it. That's why I suspect these results are real. Now, obviously, this was in-hospital population. These were in-hospital arrests, and our population out of the hospital is different. But I think the same issues are seen in our environment. We're probably a little bit better at doing MCDs, but overall, I still don't think we're very good at it. Now, again, I want to point out, I do think there are reasonable uses for MCDs, like we talked about before. I definitely don't want people doing CPR in the back of a truck without an MCD. It's dangerous. My number one job is to get my colleagues home at the end of the shift safely. Doing CPR, you can't do it effectively when you're wearing your seatbelt, and not wearing your seatbelt is how we get hurt. Let's not do that. But outside of those few situations, I think we need to be careful about using them because it likely lowers survival. And we also need to be aware of indication creep here. If the device is there, it tends to be used. If we have MCDs somewhere on the truck, we need to have clear protocols and follow those protocols on when and how to use them. Well, that's about it for now. I was going to say I haven't decided which MCD paper to cover next, but I think I'm going to do Lewis's paper about Austin's QI project. And then I think I'm going to get into the RCTs because, to be honest, they have the bestest names ever. Paramedic and LINC and CIRC. Great names. I want to talk about those in future episodes. Well, as always, thank you for listening, and thank you for the care you give your communities every day. I hope y'all have a safe and happy New Year, and I hope I get this sucker published in this year. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the Flightbridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.